is going to be Glen Peterson. He is an associate professor here at the University of Colorado and the Education and Quality Clinical Director for the APP group within our division of hematology. Welcome, Glen. We're really excited to hear all that you have to tell us today about oncologic emergencies in AML.
Great. Thanks, Meredith. Welcome, everybody, to our Heme Symposia. Really appreciate you guys coming today. So we're going to talk about oncologic emergencies and acute myeloid leukemia. As we all know, this is a a disease that sometimes patients come in pretty difficult scenarios and situations and can develop a lot of complications related to their disease and treatment. So we'll kind of discuss onc emergencies, but I think a variety of other things really kind of leading up to that. So we'll talk about the clinical presentation of AML. We always think that's a pretty important, part of how they're going to, what their outcomes are going to look like as they progress through treatment. We'll talk about the common physical exam findings in newly diagnosed and relapsed AML. We'll describe some of the management of the complications associated with AML and also complications associated with the treatment of acute myeloid leukemia. So in the upper right-hand side, these are these beautiful blasts, as one of our pathologists always used to say, these big purple blasts. And of course, there's nothing beautiful about leukemia in any patient. But AML is the most common acute leukemia in adults. It's typically a disease of the elderly. More than half of patients are diagnosed over the age of 65 and about a third over the age of 75. It's a heterogeneous disease with heterogeneous presentations. It has universally poor outcomes, especially in the elderly population, but treatment options are expanding. So AML, there's around 20,000 cases of AML diagnosed each year. They're about 1% of all new cancer cases, but about 2% of all deaths. And you can see there on the upper right-hand side, the 5-year relative survival is only about 30%. So not all AMLs are created equal. They're not equal based on their genetic risk of the disease or risk classification. They're not equal by the age that they present. And then they're very heterogeneous in their clinical presentation. So some patients come in maybe with a nice low white blood cell count. They stay nice and stable throughout treatment. But other patients come in kind of like a freight train. So other patients come in, like I said, with a much worse clinical scenario with a variety of potential complications. All right, the risk classification of acute myeloid leukemia. We know that patients are divided into several different categories, either favorable, intermediate, and poor risk in this classification. In regard to risk and survival, we know that patients who are in the have much different outcomes. So the favorable risk patients do better than the intermediate and unfavorable risk patients also. But anyway, so RJ is a 68-year-old male with a history of type 2 diabetes, hypertension, had a MI, who presents to his primary care doctor with 2 weeks of low-grade fever, fatigue, malaise, cough, and unusual bruising. On exam, the patient is having a bit of a fever, a little bit tachycardic and tachypnic, is ill appearing, is pale, has gingival hyperplasia, poor dentition, coarse lung sounds, mild hepatosplenomegaly, some scattered papular skin lesions, ecchymosis, and petechia in the lower extremities. The PCP draws labs, and unfortunately, the patient's white blood cell count is very high. They noted 80% blasts. Patient also has an abnormal creatinine, some electrolyte derangements, and a right lung consolidation and diffuse reticular opacities on chest X-ray. So the patient was sent to the emergency department of the local academic medical center. On presentation to the ED, the patient was ill appearing with a fever, and then is now becoming hemodynamically less stable with low blood pressure and tachycardia and breathing fast, and now requiring oxygen with an elevated lactate. The inpatient blood cancer team was consulted to evaluate the patient. And the patient was treated in the ED with some antisepsis interventions and then eventually transferred to the medical ICU and placed on pressors and again, further antisepsis interventions. So repeat labs in the ICU, obviously nothing is getting better, only worse. The patient is having progressive DIC and also some auto tumor lysis syndrome and still has an elevated lactate. Additional workup by our blood cancer team is kind of the typical stat peripheral blood flow, which was consistent with acute myeloid leukemia. We did a stat FISH test for PML-RARA for APL, which was negative, and a bone marrow biopsy was completed in the ICU, and again, consistent with a acute myeloid leukemia with FLT3 positive disease, and an abnormal echocardiogram also. So the patient was initiated on hydroxyurea. Leukapheresis ×2 was completed, and the white blood cell count came down to 30. The patient stabilized with improvement in vital signs, and the patient was deemed unfit for intensive induction chemotherapy due to significant comorbidities, and then patient and family preference to not have intensive chemotherapy, and was started on azacitidine and venetoclax. So in regard to AML management, so this is definitely an example of a case of a hyperproliferative aggressive acute myeloid leukemia, but really not all patients present like this. But the question is, how will your patient present? And when we think about acute myeloid leukemia patients who come in to the hospital, we kind of think about three big categories. One is clinical stability, and then getting the diagnosis and getting going with treatment. And all of this should be done in a very quick time frame. So some of the common exam findings we see in acute myeloid leukemia, this is what oftentimes a proliferative AML will present with. So significant anemia, potentially gingival hyperplasia, especially with our monocytic leukemias, potentially papular non-tender skin lesions of acute myeloid leukemia. Some patients will present with pulmonary failure, either due to infection or fluid overload or capillary leak syndrome in the face of hyperleukocytosis. Some patients will have hepatosplenomegaly also, and of course, bruising, purpura, and petechia in the face of thrombocytopenia and possibly DIC. Or patients will come in, and I think we see a number of these patients, especially in Colorado, where they really don't have much besides maybe a little fatigue when they're, hiking a big hike with their friend, and they just couldn't keep up. So again, we get quite a range of clinical presentations in patients with acute myeloid leukemia. So some of the common lab findings in AML, in abnormal CBC, which we saw in our last patient, anemia, high or low white blood cell counts, relatively low neutrophil counts, potentially blasts on the differential, electrolyte and metabolic derangements, and then coagulopathy in the face of DIC. So putting the puzzle together, I think this is an important slide. We know that our physical exam, talking to our patients and doing our exam, including our review systems and physical exam, labs and other diagnostic testing, leads us to the identification and treatment of serious medical conditions in acute myeloid leukemia. So the first thing to think about, again, in the most important, and especially in that first 24 to 48 hours that the patient's in the hospital, is their clinical stability. And we think about kind of four big complications in acute myeloid leukemia. We have hyperleukocytosis causing leukostasis, tumor lysis syndrome, DIC, and sepsis. So these are kind of the big complications that we see and that we worry about for AML patients who present to the hospital. So hyperleukocytosis causes hyperviscosity that may result in tissue ischemia, infarcts, and thromboembolic events. Mental status changes or stroke-like symptoms, respiratory insufficiency, priapism, extremity compartment syndromes can develop in the face of leukostasis. Cytoreduction is really the main thing that we do to deal with this. So we have to bring the white blood cell count down with hydroxyurea is kind of our first upfront start of management of this, and then leukapheresis. And it's a little unclear how many patients benefit from leukapheresis, but probably are highly proliferative AML patients that are not, that were having trouble lowering their white blood cell count down with hydroxyurea, probably benefit from leukapheresis. And we like to do this prior to the initiation of therapy. Getting the white blood cell count down reduces complications of leukostasis and complications of treatment, such as tumor lysis syndrome and DIC. And then we get these patients going to treatment as soon as possible. In regard to tumor lysis syndrome, so this is a life-threatening condition that occurs after cellular destruction of rapidly growing tumors, and then the release of potassium, uric acid, phosphorus, and then resulting renal failure. We know that clinical tumor lysis may result in rapidly progressive renal failure, seizure, and cardiac dysrhythmia, leading to death. And the treatments for this, of course, we start off with IV fluids, allopurinol. We use allopurinol to reduce the production of uric acid, and then we can use respiricase to rapidly reduce the circulating uric acid in the blood. We get frequent labs to monitor these patients for these electrolyte abnormalities. Potentially every 4 to 12 hours would be pretty common. We follow these patients with telemetry and get EKGs intermittently, especially if they develop a bit of hyperkalemia, and then manage the electrolytes. And again, especially the potassium, we want to bring potassium down to normal levels to prevent significant cardiac complications. And then renal replacement therapy is something that we do in the face of climbing potassium and evidence of significant tumor lysis syndrome. We talk to the renal team, and sometimes even as we start treatment or prior to starting treatment, may want to start continuous renal replacement therapy. This is our tumor lysis guideline that we use here. It's a really nice guideline that was produced by one of our PAs, Lucy Logan Spears. All right, so moving on to DIC. So DIC is an oncologic emergency that develops secondary to an underlying pathologic condition. So typically malignancy in our world, but certainly infection and sepsis can induce DIC. So DIC is a coagulation disorder characterized by widespread intravascular thrombosis, causing tissue ischemia and organ dysfunction. In addition to this, we have a consumptive depletion of coagulant factors and platelets that contribute to hemorrhage. And I would say that our patients in the blood cancer world definitely have more hemorrhage than they do clot, but sometimes have both. We, of course, monitor these patients with frequent labs potentially every 4 to 12 hours also. And then we replace blood products depending on what their labs show. So if they have a low platelet count, say below 30 or even 50 in patients with acute promyelocytic leukemia, we'd give platelets. For patients that have an elevated INR, we give FFP, a low fibrinogen, we give cryoprecipitate. And we need to stay pretty aggressive with this blood product repletion to reduce the risk of hemorrhagic complications. And then, of course, treating the underlying cause. Of course, DIC never gets better unless we treat the underlying cause. All right, so sepsis. So sepsis is really our most concerning complication in all of our blood cancer patients. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is a subset of sepsis with circulatory and cellular or metabolic dysfunction associated with a higher risk of mortality. So patients who we suspect sepsis on, we of course give them volume. We do a quick ID workup and start antibiotics. And we want to start antibiotics just as quickly as possible. It's the most important intervention in interrupting sepsis in any patient, and especially cancer patients. Of course, we send some patients to the ICU if needed for steroids and pressors, mechanical ventilation, and so on. And then getting the diagnosis. So, again, our initial concerns are based on our review systems and physical exam, just like our case where the PCP had concerns through labs and which showed, this hyperleukocytosis. Stat blood studies. So we do stat peripheral blood flow, so we can determine what lineage of acute leukemia this is, myeloid or lymphoid. And we do FISH studies for the actionable mutations, such as PML-RARA for APL and the BCR-ABL for the Philadelphia chromosome in ALL or CML. And then we get a bone marrow biopsy and do some of the same studies. We'll have a morphologic or pathology review with immunohistochemistry, flow cytometry, cytogenetics, and FISH. We'll do a next-gen molecular sequencing, and then study-related samples. And then getting going with treatment. So we know that nothing gets better with treatment. So treatment considerations in AML. So what are our options? Thankfully, we do have options now. There was a long period of time, probably 4 decades or so, where there was really no improvement over standard induction chemotherapy, which is toxic. Many patients, actually probably the majority of patients, don't tolerate well. But over the last 5 years, there's been a lot of changes in the landscape of acute myeloid leukemia treatment with the introduction of venetoclax and other targeted therapies. So now we have the decision to make of intense versus less intense. And this decision is based on a combination of factors, including disease characteristics. So what is the risk classification? Is this an antecedent heme malignancy? Or is there an antecedent heme malignancy? Is this a therapy-related AML? So we have some options, both on the intense and less intense side of things in regard to treatment. Also patient characteristics, and this is really important. So the patient's performance status, any comorbidities that they have, physiologic age. So, physiologic age is obviously more important than chronologic age in general when trying to decide on the intensity of treatment. And then their social situation. Can a patient go through intense induction chemotherapy and maintain all of the kind of responsibilities for follow-up that we need to do for these patients? And just kind of a quick review of kind of what we do these days for AML treatment. So this is acute promyelocytic leukemia, and for a long time we've used the combination of ATRA and arsenic to treat these patients with excellent outcomes. Almost all patients go into remission, and almost all patients are cured with this combination of therapy. And then we have our standard acute myeloid leukemia, or non-APL acute myeloid leukemias that are kind of divided into risk. And there are some options in these categories. So for our favorable risk AMLs, induction chemotherapy with the addition of gemtuzumab, which is the CD33 targeted antibody drug conjugate that has shown benefits in patients who go through induction chemotherapy and have good risk or core binding factor AMLs. And then in patients who have certain mutations, certain targetable mutations like FLT3, we can add midostaurin or a FLT3 inhibitor to this regimen. And then our poor risk patients, there are kind of a variety of different things we can do. Standard induction chemotherapy, azacitidine, venetoclax for some of these patients. And these are intensive induction eligible type patients. So these are patients that could potentially tolerate induction chemotherapy. And in those patients, you can use intensive chemotherapy, but also azacitidine and venetoclax as a reasonable combination. Some patients who, again, have a therapy-related AML or an antecedent MDS or CMML, there is another medication that can be used. It's similar to induction chemotherapy, but maybe slightly less intense, is CPX-351. It's a dual drug liposomal cytarabine and daunorubicin, which is an option for those patients. And then again, azacitidine and venetoclax for those patients also. Patients that don't have, so patients that are not candidates for intense chemotherapy, this is the most important, I think, kind of revolution in AML therapy, since most of our patients are not great candidates for induction chemotherapy, with more than half of all adult AML patients being diagnosed over the age of 65 and into their 70s is kind of the average. So in really all patients who we don't think can tolerate induction chemotherapy, we have options. So azacitidine and venetoclax has obviously been shown to have probably superior remission rates, and of course a lot less toxicity compared to standard induction chemotherapy. Patients with IDH and FLT3, even in those patients that have another targetable mutation, azacitidine and venetoclax has proven to be very effective. But those patients can, and maybe in combination with something else like azacitidine, can be treated with IDH inhibitors and FLT3 inhibitors also as an option. So venetoclax, I know we've talked a lot about venetoclax in multiple different talks, but just kind of a quick review of some of these targeted therapies that we use for AML. So venetoclax is a BCL2 inhibitor. We know that BCL2 is an anti-apoptotic protein that is overexpressed on the leukemia stem cell, and inhibiting BCL2 induces apoptosis of leukemic blasts. It's FDA approved for use in combination with azacitidine or decitabine or low-dose cytarabine for the treatment of newly diagnosed acute myeloid leukemia in adults who are age 75 years or older, or who have comorbidities that preclude the use of intensive induction chemotherapy. And the NCCN recommendation now is really anybody over the age of 18 that is not a good candidate for intense induction chemotherapy could be a good candidate for azacitidine and venetoclax. Azacitidine and decitabine, so the hypomethylation portion of this combination causes hypomethylation of DNA and direct cytotoxicity to abnormal hematopoietic cells in the bone marrow, and then induces cellular differentiation or apoptosis. And I just want to mention this. This was a kind of a cool abstract that Dr. Pollier was involved with at the most recent ASH, and they looked at the ELN risk stratification in patients who are treated with azacitidine and venetoclax, and determined that that classification is not predictive of outcomes for treatment naive patients with AML who are treated with azacitidine and venetoclax. And with the ELN criteria, we have our three categories: favorable, intermediate, and adverse. And patients who are treated with azacitidine and venetoclax seem to be able to overcome some of those adverse risk factors, and actually puts them more in two categories of poor and intermediate. Again, more of those patients in the adverse risk group end up in the intermediate group when treated with azacitidine and venetoclax based on outcomes. And you can see in this graph below that there is much less difference between the three ELN groups in patients treated with azacitidine and venetoclax. Again, just showing that venetoclax in combination with azacitidine seems to be able to overcome some of those adverse risk factors that we have previously seen in the adverse risk group of the ELN. FLT3 inhibitors, and again, I just want to kind of talk a little bit about each one of these targeted therapies and in kind of relation to an upcoming complication that I'm going to talk about that they're all known for. So FLT3 inhibitors, so these FIMS-like tyrosine kinase 3 mutations, induce intracellular signaling pathways, triggering leukemic cell proliferation and anti-apoptosis. FLT inhibition induces apoptosis, cell cycle arrest, and differentiation. FLT3 is the most common genetic abnormality we see in acute myeloid leukemia. And you can see we have several of these FLT3 inhibitors: gilteritinib, midostaurin, and sorafenib. And in the relapsed refractory setting, gilteritinib appears to have a improved probability of survival compared to salvage chemotherapy. And in the relapsed refractory setting, midostaurin also shows some survival benefit compared to placebo. In patients who relapse post-allo stem cell transplant and are treated with sorafenib versus those who did not receive sorafenib and have a FLT3 relapse, the patients who receive sorafenib have an improved overall survival compared to those that do not. All right, so IDH inhibitors, enasidenib and ivosidenib. So isocitrate dehydrogenase gene mutations of IDH1 and 2 cause dysregulated DNA hypermethylation and leukemogenesis. IDH occurs in about 6 to 10% of patients with AML, IDH2 and 10 to 19% of AML patients. So probably somewhere around 20% or so of the entire population. IDH1 carries probably a worse prognosis, IDH2 a bit more favorable, and then pairing IDH with NPM1 is also more favorable. IDH inhibitors promote normal differentiation of AML cells by reversing the hypermethylation process. And you see, I thought this was kind of a neat graph showing the clinical activity of IDH inhibitors as single agents or in combination with something else like azacitidine or 7+3 induction chemotherapy. And you can see standing alone, they definitely have some, response, CR rates of, 20 to 48%. But when used in combination with azacitidine, for example, somewhere in the 60s and 70 range for CR rates. When used in combination with induction chemotherapy, kind of the mid 70s as far as CR rates. In patients in the relapse refractory setting, somewhere around 30% of these patients will still get into a CR with the use of these IDH inhibitors. But you can see kind of one of the only ones that I didn't highlight, the azacitidine and venetoclax actually has better outcomes in regard to CR and overall survival than any of these combinations. All right, menin inhibitors. So this is kind of a new class of drugs that has gotten a lot of attention recently, and we have a clinical trial open for this right now. But it is effective in relapse refractory AMLs. So menin inhibitor, we have this SNDX 5613 study. So MLL1, mixed lineage leukemia 1, also called the KMT2A rearrangements on chromosome 11q23 occur in about 5 to 10% of adult AMLs. MLL translocations form protein complexes that upregulate leukemogenic genes, and menin is essential to locate leukemogenic protein complexes to chromatin. And so inhibiting this interaction between MLL and menin downregulates a couple of transcription genes and reverses leukemogenesis. And in the kind of the first phase of this study, they showed pretty good, CR and CRh rates of about 30%, an overall response rate of about 60% in patients with MLL gene rearrangement. This is active against NPM1 also. And then let's see. So the combination is about 27% of patients had a CR or CRh and is observed in both the NPM and KMT2A relapse refractory acute leukemia patients treated on the phase 2 dose. And then patients who underwent a stem cell transplant after achieving a response to the SNDX 5613, 9 of 12 of these patients remained in remission, with 4 of them continuing beyond 1 year. So it's kind of an exciting another option for these relapse refractory patients, especially after like treatments with like azacitidine and venetoclax and so on. So I want to run through a case that kind of highlights, a scenario that can occur with menin inhibitors. So this is a 72-year-old male with hypertension, type 2 diabetes, who was transferred to UCH with low blood counts and found to have 50% blasts in the blood. A bone marrow biopsy was completed and revealed a acute myeloid leukemia with a KMT2A rearrangement. The patient unfortunately failed 2 cycles of azacitidine and venetoclax and was started on the SNDX 5613 menin inhibitor trial with a plan to proceed with allo stem cell transplant if he responded. So the patient came into clinic and was noted to have an increasing white blood cell count after starting on the SNDX trial. The white blood cell count was about 12, no other clinical signs of differentiation syndrome. However, later that day, the patient's caregiver called to report the patient was fevering, was short of breath, and had significant weakness. of course, had no blood, no neutrophils, flat neutropenic. The caregiver was unable to safely bring the patient to the emergency department, therefore was instructed to call 911 and came into the emergency department for further workup and management. So the BMT APP saw the patient in the ED and noted significant work of breathing, progressive hypoxia, now requiring 10 to 12 liters of oxygen, fever, and then a rapidly rising creatinine from about 1, and I think even maybe 0.8 to 2.5. Worsening pulmonary infiltrates on chest x-ray, and there became a real concern of the possibility of differentiation syndrome. Of course, a difficult clinical scenario, and infection or a combination of the two was also on the differential. The patient was transferred to the MICU given the worsening and rapidly worsening pulmonary and renal failure. The patient was started on dexamethasone, 10 milligrams IV Q12, with a plan to start hydroxyurea if the white blood cell count went to 15. Lasix was given as needed, tumor lysis and DIC monitoring, and then of course the patient was treated with IV antibiotics for pneumonia and sepsis. The SNDX 5613 study drug was continued. The patient started to improve with less hypoxia. A few days later, however, the patient developed signs of tumor lysis and worsening hypoxia and differentiation syndrome with a rising white blood cell count and worsening pulmonary infiltrates. The study drug was held and hydroxyurea was increased. The patient eventually responded to these interventions with resolution of hypoxia. Tumor lysis syndrome resolved, and the steroids were tapered off over a couple of weeks. The hydrea was discontinued as the leukocytosis resolved, and then the study drug was resumed with no recurrence of differentiation syndrome. A bone marrow biopsy was completed after discharge, and the patient was noted to be in that category of patients that went into a CR. This is a kind of an example of what a chest x-ray and CT scan can look like in the face of differentiation syndrome. So on the left, this is day 1, and then 5 days later, pretty significant worsening of pulmonary infiltrates, which then again did improve. All right, so differentiation syndrome. So this is overall in general a rare but important complication in patients with AML. But there are certain anti-AML therapies that are known to cause differentiation syndrome. In APL, of course, arsenic and ATRA have like 25 to 30% of patients will develop some degree of differentiation syndrome, which the median onset is about 12 days. I've definitely seen patients develop differentiation syndrome after the first dose of ATRA in APL. For non-APL AML, IDH inhibitors, menin inhibitors, FLT3 inhibitors, and then a few patients on hypomethylators can develop differentiation syndrome. So for IDH inhibitors, there's a slightly higher incidence with ivosidenib. 19 to 25% of patients can develop differentiation syndrome compared to enasidenib at 12 to 14% with similar onset of around 30 days. Menin inhibitors in the phase 1 trial, the SNDX trial, differentiation syndrome occurred in about 16% of patients. For FLT3, this is a more rare situation, but gilteritinib is noted to develop differentiation syndrome in about 3% of patients, less than sorafenib and midostaurin. So the mechanism of differentiation syndrome is not completely understood, but likely similar cytokine-mediated processes for all drugs, occurs when patients develop differentiation syndrome. Differentiation syndrome is characterized by unexplained fever, leukocytosis, weight gain, edema, dyspnea, and or hypoxia, interstitial pulmonary infiltrates, pleural pericardial effusions, hypotension, and acute renal failure. So this condition is challenging, and I think in our case, looking at how these patients present, and these are relapsed refractory acute myeloid leukemia patients who are ultra high risk for developing infectious complications. and other complications. And so I think, being aware of differentiation syndrome, especially since it does mimic other conditions, is very, very important. Some risk factors that are associated with the development of more severe differentiation syndrome are an elevated white blood cell count, probably above 10, and an elevated creatinine. So these patients do worse with differentiation syndrome than others. The mortality of DS in early APL studies was 5 to 9%. Now, since we've learned a lot more about differentiation syndrome, and we use prophylactic prednisone and get on board with steroids pretty quickly, the mortality rate is about 1% in patients with APL who develop DS. About 5 to 6% in patients on IDH inhibitors. And in the first phase of the Syndax trial, there were no deaths related to differentiation syndrome in those 16% of patients. So this is kind of what happens with differentiation syndrome. So you have your leukemic blast floating around, and then you add something that targets these cells like ATRA, arsenic, IDH, FLT, menin inhibitors. And this creates this differentiation process. And with differentiation, there are a lot of cytokines and chemokines that are developed or that are released, and you develop this major cytokine storm, and a systemic inflammatory response syndrome results. So as these cells differentiate, you can see on this chart, these are more like monocytes and granulocytes at this point. There's increased adhesion molecules, which causes more adhesion to the endothelial lining of blood vessels. And then these more mature differentiated leukemia cells then extravasate into through the blood endothelial through the vessel lining into tissues, causing significant capillary leak syndrome and tissue damage. And this resulting clinical syndrome of fever, leukocytosis, fluid overload, and pulmonary failure, and some patients even ending up with multi-organ failure in the ICU. So it can be pretty dramatic and can cause patients to decompensate very quickly. Switching gears just a little bit, I just thought this was kind of a neat representation of what happens with differentiation and really what that looks like under the microscope for patients treated with FLT3 inhibitors and really other types of treatment. So this is a gilteritinib example, and you can see on the left-hand side, these are the leukemic blasts, but on the right-hand side, you can see a lot of these more mature myelocytes, and these again are looking more like granulocytes, like neutrophils. This is another one showing these much more mature and developed myeloid cells. So just thought that was kind of interesting. For IDH inhibitors, I thought this was kind of a neat kind of depiction of what happens in patients who develop differentiation syndrome and who are receiving IDH inhibitors. So it compares on the top part of these graphs, it compares the peripheral blood with the bone marrow. And you can see in this patient, so this patient developed differentiation syndrome 3 separate times. And it looks like each time, the patient had a rise in neutrophils, at the time of or shortly prior to the differentiation syndrome. And then looking in the bone marrow, you can see that there are far more, increased development of mature granulocytes. And then at the same time as the differentiation is happening, obviously the myeloblasts kind of drop like a rock. And then in this one on the bottom, this patient had a single episode of differentiation syndrome and did not recur. This patient didn't really show a big increase in neutrophils, but if you look in the bone marrow, his bone marrow is, or this person's bone marrow was pretty packed with myeloblasts. And so I'm sure the white blood cell count was probably high. They just didn't have neutrophils. But you can see as differentiation syndrome occurs, the bone marrow blasts drop, and then the more mature granulocytes start to develop, and then eventually see that in the peripheral blood also with increasing neutrophils. So one question I think that I had is, does differentiation syndrome improve response? And, looking at IDH inhibitors at least, in patients with ivosidenib or enasidenib who developed differentiation syndrome, it looked like actually a lower percentage of those patients went into CR or CRH. In really kind of both scenarios, patients with differentiation syndrome had lower rates of CR. And then, I have read other papers that said maybe there is a slight, difference in response rates, maybe a little bit of an improved response rate in some studies and in certain with certain targeted therapies. But the one thing that was pretty clear, at least in this study, is that in regard to overall survival, definitely patients who developed differentiation syndrome had a lower overall survival, at least in ivosidenib, had a pretty significantly lower overall survival compared to those that did not develop differentiation syndrome. It looks like in the enasidenib group, it's pretty similar, around 8 months, but didn't seem to improve anything for sure. So the management of differentiation syndrome. So, APL is kind of our most established, knowledge of differentiation syndrome because we've been dealing with it for a long time. The NCCN guidance for APL differentiation syndrome basically says to use dexamethasone at the first sign of differentiation syndrome, 10 milligrams twice a day for 3 to 5 days with a taper. And then consider interrupting ATRA and arsenic therapy until the hypoxia resolves. For patients who have an elevated white blood cell count, prophylactic use of corticosteroids with prednisone or dexamethasone is probably useful. And if patients develop differentiation syndrome and they're on prednisone, then switch to dexamethasone. Other cytoreductive strategies for leukocytosis with differentiation syndrome may be hydroxyurea and anthracycline or gemtuzumab. And we have used gemtuzumab on rare occasions, but it's been some time, I think, since we've had to use an anthracycline. So what do we do? So, with our ATRA and arsenic regimen, we do prophylax these patients with prednisone, 0.5 milligrams per kilogram per day. And, we tend to continue this for several weeks and then taper it off by day 28. If a patient does develop differentiation syndrome, we use dexamethasone 10 milligrams IV Q12 for 3 to 5 days. And then we stop this if their symptoms resolve and then resume prednisone prophylaxis for the typical course. If we use dexamethasone for an extended period of time, say greater than 7 days, we do taper those patients. If differentiation syndrome is severe, where we have progressive hypoxia that could potentially lead to, high or used, transfer to the ICU or intubation, then we would likely hold this therapy until the patient improves on steroids. Hydroxyurea, if the white count is greater than 10. So, we're pretty conservative with this. If the patient is nearing 10, we start hydroxyurea and then titrate up to keep the white blood cell count below 10. In our experience, gemtuzumab or anthracyclines are rarely required for our patients with low-risk APL who develop differentiation syndrome. We're able to, with the kind of early use of hydroxyurea, able to manage the white blood cell count. And then because patients are on a lot of steroids, we want to give these patients antibiotic prophylaxis. So we use anidulafungin if we're trying to prevent QT prolongation in patients requiring antifungal. We can use Cresemba or isobuconazole if we need to shorten the QT due to arsenic administration. Acyclovir, Bactrim, and then Levaquin or cefpodoxime. We probably use a little more cefpodoxime, especially due to the risk of QT prolongation with arsenic. And we use this if the ANC drops below 500. For non-APL DS management, so this would be in the face of our IDH and FLT3 inhibitors, there is some, some guidance. And so basically, it's, I think, very similar in a lot of ways. If we suspect differentiation syndrome, of course, you want to evaluate for other conditions like infection, heart failure, and so on. But we initiate dexamethasone right away. And, if the patient improves, great, we can, once their symptoms resolve, we can reduce or taper the dexamethasone. If they do not improve, we can increase the dose of dexamethasone. If still after another 24 to 48 hours of higher dose dexamethasone, the patient is not improving, then discontinuing the differentiating agent, like the IDH or FLT3 inhibitor. And again, IDH inhibitors is a much more common occurrence than FLT3s. But, one thing to remember is that stopping IDH inhibitors alone doesn't fix the problem. These drugs have a very long half-life of up to like 137, 138 hours. And so stopping today, won't fix the problem for days. So that's just something to remember. So differentiation syndrome with menin inhibitors. And again, we have the Syndex trial going now. But again, some similarities in how we manage differentiation syndrome really across all drugs. So if a patient develops signs of differentiation syndrome, we promptly initiate treatment directed at differentiation syndrome as soon as the diagnosis is suspected. So oral or IV corticosteroids, typically dexamethasone, 10 milligrams every 12. We would keep this treatment on for a minimum of 3 days and only taper the steroids if they have resolution of their signs and symptoms of differentiation syndrome. If they have severe symptoms of differentiation that last for 48 hours or more after initiating corticosteroids, then we should interrupt treatment and then only resume the menin inhibitor when their symptoms improve down to grade 2 or lower. Leukocyte count of 25, we definitely, based on the study, would initiate hydroxyurea and then just kind of follow that along based on our kind of institutional practice. Leukapheresis could be used in patients who are uncontrolled on hydroxyurea. And of course, kind of simple supportive care measures like furosemide or other diuretics may be useful to reduce pulmonary failure related to differentiation syndrome in these patients. All right, so these are just some questions that I had, when dealing with menin inhibitors. What is kind of our best approach? Again, it hasn't been standardized with differentiation syndrome. I know in our APL, guidelines, we initiate hydroxyurea earlier than what the kind of protocol states at a leukocyte count of 25, and then titrating that hydroxyurea to keep the white blood cell count less than 10, and then considering prednisone prophylaxis. And again, on study treatments, these are, I think, questions, and we can only do what we can do, but I just wanted to kind of bring it up for potential discussion. So in conclusion, AML is a challenging disease, especially in the elderly population. Major complications can occur, again, due to the disease and to the treatment. Tumor lysis syndrome, DIC, sepsis, leukostasis, and differentiation syndrome can be a real problem for these patients. More options for treatment are now available. Targeted therapies offer improved outcomes with fewer toxicities. Management of differentiation syndrome is similar for all DS-inducing treatments, and clear management strategies are required to reduce morbidity and mortality related to differentiation syndrome. So that's pretty much it. Does anybody have any questions or comments or thoughts?
That was awesome, Glenn. Thank you so much. If anybody does have questions, you can throw them in the chat. You can unmute yourself. You can raise your hand.
Okay, so I do have a question here. So do steroids interact with meds that aren't arsenic like gilteritinib or inacitinib? Would it be an option to give steroids at the first sign of DS like with APL? Would it help mitigate a hole in the medication, or do you always need to hold the medication to treat DS while on steroids and then restart when it gets better? So yeah, so steroids don't interact with the medications. And, of course, we don't like to use steroids in, relapse refractory acute myeloid leukemia patients or patients, they're going to be neutropenic for an extended period of time. So, we certainly are thoughtful when giving steroids. But certainly in the face of DS, which is a life-threatening complication, we definitely use it in all of those scenarios, whether it be FLT3, IDH, or APL, treatment with arsenic and ATRA. And holding the medication, I think, it depends on the severity of differentiation syndrome. The pulmonary failure thing is a big deal. And so patients that are, showing a need to rapidly increase, their oxygen, have a rapidly increasing oxygen demand, we should probably consider holding these medications, because avoiding, the ventilator, I think is important. And then, yeah, once the differentiation syndrome, resolves or reduces significantly, restarting those drugs is an important part, because obviously, the overall picture is not going to improve without the treatment. Okay, any other questions?
Glenn, has there been any talk about specifically with those menin inhibitors doing some of the steroid prophylaxis for those, or just treating when symptoms arise?
Yeah, no, I think, there was about 16% of patients that develop differentiation syndrome. So not a tiny number. And definitely patients can have pretty poor outcomes. And so that was something actually just kind of Jeff and I were kind of talking about it a little bit. And I think we probably, need to regroup on this and could you, do something kind of similar, as we do with APL. I think it's a little bit challenging because, these patients, they're the relapse refractory, setting is tough in regard to other complications, like we kind of talked about with, risk of major infectious complications, fungal infections, and others. So I kind of doubt that we'll, prophylactically use steroids for an extended period of time, but I think it's worth a discussion for sure.
Great.
Is there anything else?
Any other questions, anyone? Or well, this has been amazing. And very, very educational, I think, for all of us who are dealing with our acute leukemics and leukemics who have relapsed and trying to treat them. Thank you so much for everyone who was able to attend today. We really appreciated it. All of the information for the CE credit is in the chat. So if you want to click on those links, that's available to you as well. And yeah, we hope everybody has a great rest of their day. Thank you so much, Glenn. And we'll see everyone again next time.
All right. Thank you, guys. Thanks, Meredith.